So welcome to the presentation on psychosocial support, mental health and psychosocial support during COVID-19 and the learnings from previous disasters that we have asked Barbara Juen, who is the scientific advisor for the European Network for Psychosocial Support, to present to us today. Barbara is working on this topic and has done for many, many years as a professor at the University of Innsbruck and also as the key person in Austrian Red Cross. So let's look at the learnings from several MHPSS disaster responses from different contexts and talk about the model of ABC after, before crisis, and discuss what we can do and what we can learn from COVID-19 to improve our interventions. So I'm here, Suzanne Akasha from the Reference Centre for Psychosocial Support. And Barbara, would you say a bit about yourself and your work?
Thanks, Aya. I am a professor at the University of Innsbruck. I'm a psychologist, a clinical psychologist, and at the same time, I am the psychosocial head of psychosocial support, the psychological head of psychosocial support in the Austrian Red Cross. Monika Stickler, who is also part of this presentation, is the organizational head of psychosocial support. In the Austrian Red Cross, we have now for more than 20 years, we have this psychosocial system where we go with the ambulances and support people after acute traumatization, also after small events like a suicide or the death of a child. But we also go into bigger events. We have around 3,000 missions a year in this system, and we have around 2,000 volunteers working in the system. So it's a rather big experience that we have. And in the university, we do research on that topic, on the acute traumatization.
So thank you for that. We are very keen to learn from you because the Austrian Red Cross and from your studies at the university, there's a lot to learn. So please start the presentation on the psychosocial effects of COVID-19, if you would please.
Good. I will start with a smaller presentation about the disaster cycle and about where I see our main efforts that have to be done at the moment. If you look at the disaster cycle, we see the response, recovery, mitigation, and preparedness phase. And the main thing about this disaster cycle is that it's about awareness. It's about a reflection, a reflective position on the disaster. If you put it in a very simple sentence, then you can say after the disaster is before the disaster. And it's when we talked about this in our last ENPS forum, which is in 2019, we said we always have to be aware that the next disaster is coming very soon. So we have to be well prepared. We said in the preparedness phase, we have to promote resistance by doing capacity building within our own organizations. In the response phases, we have to do the psychological first aid, psychoeducation, the whole psychosocial approach, and promote recovery by activating the resources. And in the recovery phase, we have to promote growth, like learning from what we have been experiencing. And paradoxically, what we experience at the moment is, if we look at the pandemic intervention phases, I'm now showing you just the epidemiological intervention phases, like how to deal with the infection. Here you see you have an overlap of phases. While in the beginning, you focus on detection and containment when you don't have many cases. Then you can do that. In the further course of the pandemic, you have to also protect the vulnerable groups, like the older people in our pandemic now. And in the further course of the event, when you have many cases, you have to really focus also on the mitigation of effects. And in the phase we have now, we have to focus on all three things at the same time. And it's rather similar for our psychosocial approach. At the moment, we have the difficult situation that we have to focus on all phases of the disaster at the same time. We have to do capacity building, we have to do interventions, acute interventions for people who experience stress now. And at the same time, we have to focus, to reflect, to focus on what we learned from the disaster. And that's rather difficult and rather complex what we have to do now. So that's just the background for what I want to say about the background regarding the disaster that we face now.
And just a brief comment from my side, I found this model very helpful when planning trainings at the moment, because I think it helps me structure and helps us structure what it is we have to do. So thank you for that.
So let's go back if I can. Can you see the psychosocial effects of COVID-19 now on your screen?
Perfect. It's perfect. Thank you.
Okay, super. I didn't know if it worked. So what we can do now is have a short look on the research. What I have to say at the moment, for a researcher, this is a very exciting time, because at the moment so much research is going on you cannot imagine. And so this is just a short glance on what is going on at the moment. And I'm sure next week, the week after, we will have enough new studies coming on about this topic. But this is a glance on what we have now in October 2020. So if we look at the science, what we can say now, what we already can say is, what we see is that the COVID pandemic enhances existing inequalities in an extreme manner. Especially groups who are less privileged suffer more from the pandemic, and the measures, the non-pharmaceutical measures, than those who have more privileges. You can, for example, look at home office, for example. Home office is something for the privileged. Only the privileged people can do home office. And only the privileged people can do home office in a way that they don't get completely exhausted. Like home office for some people, for families, when they had to do home office and at the same time had the children at home, was almost, with homeschooling, was almost impossible. And the next thing is that resilience and vulnerability become much more visible during the pandemic. Everybody sees the pandemic gives us a view on our vulnerabilities, but also on our resiliences. And this both on an individual and on a group community level. So also in communities, also in organizations, we see resilience and we see vulnerabilities. And the old vulnerabilities that we have seen before, but not so clear, they come into vision. So we see them. And then we also have new vulnerabilities to come into focus, like the young adults as a vulnerable group that we have not seen before. So if you look at the main findings, this is the main findings that we have at the moment. We see in many studies, perhaps just to explain, I took out mainly studies that are on the one hand meta-analysis or reviews. So you see really a generalizable findings. So I didn't take out small findings where there are not many studies that say the same. So these are the facts that we can generalize at the moment. Younger people have more stress than older people. You see in all the studies, you see that younger people are experiencing more stress, they are experiencing more anxiety, they are experiencing more depression. They are also experiencing more conflict and more violence than older people. Women have more stress than men. Women are an especially vulnerable group in all disasters, but in this disaster, because of, for example, we name this intersectionality, because many factors often come together for women. So women more often work in difficult working circumstances. So women more often work in very exposed areas, like in the healthcare sector or in a sector where they are in a supermarket. So women are more often exposed than men. And women often have more double responsibilities, like at the same time working at home and having the children at home. What we saw during the lockdown, the first lockdown in many countries, is that traditional role models enhanced in the families. So it was very normal for the men to be in home office and not to look after the children. But for the women in home office, it was also very, very common that at the same time they had to do the shopping, the cleaning, the children and everything. While the men were in their office at home and worked the whole day. This is not for everybody, but this is what happened in general. Healthcare workers have much more stress than the general population, on the one hand because they are more exposed to the virus, yes, but on the other hand, we also saw in previous pandemics that healthcare workers have a lot of stress, especially when they are in quarantine. So when they have to go in quarantine, when they have to sit at home and are not able to do anything, they are extremely stressed. And they need a lot of support, especially by the leadership, and especially support that goes into protection, especially support that helps them to keep their trust into the organizations. We can talk about this a little bit later. And then we see that socioeconomic factors play an important role. Unemployed people or people with lower socioeconomic status are much more at risk than people who have more privileges and more resources. Students are more at risk. Students as a group of the younger people are more at risk. We think because of two factors. One factor is that they see their whole future endangered. It started during the climate crisis. We did studies on them before in 2019, and we saw that also in 2019 students had higher scores in stress and depression than other age groups. And now in the corona pandemic, you see it again. At the moment, they have higher scores, especially in anxiety. So you have a generation which is often by the media called the lost generation, which enhances this effect. So how the media and the public is looking at this age group is enhancing the problems, because on the one hand they are stigmatized as virus spreaders. They all go to parties and don't care for anything. They are seen as the lost generation, like we have already lost them because they don't get enough education at the moment, and so on. And this enhances their problems. And people with previous mental health problems are much more at risk. What we see, what the psychotherapists are saying at the moment is, what we see is that people who had a psychological problem before now has an additional problem, especially in the field of traumatization. Especially traumatized people are at the moment have so many triggers that they are re-traumatized in a way by the corona crisis. Yeah, that's a lot.
Thank you. It gives a very good overview of the situation right now. And I especially thought when you presented about the climate change crisis. So I'm happy that you see that these two things combined make it much more difficult for younger people. Thank you for clarifying that.
What I want to do now shortly is go through some exemplary studies. These are just some examples who show what happens and who show a little bit more about the risk factors and the resilience factors that we are facing at the moment. So this is one big study, one of the big studies, a meta-analysis about studies done in China, Spain, Italy, Iran, the US, Turkey, Nepal, and Denmark. And what you see there is that there are relatively high rates of symptoms of anxiety. This is perhaps also very important. All these studies I'm referring on are not measuring pathological symptoms. They are not measuring pathology. It's not about an anxiety disorder or depression as a disorder. It's about depressive symptoms, anxiety symptoms, stress symptoms. And the stress symptoms or the anxiety symptoms go from 6 to 50%, and 50% is a lot, depending on the measures often. Because if you use a rather strict measure that is more trying to define the pathology, then you find lower levels. If you use a more broader measure, then you find higher levels often. High level of this depression from 14 to 48%. Post-traumatic stress disorder also, 7 to 50%, psychological distress, around 40%, and stress in general, around 8 to 81, depending on the measure. So what you see is there is a lot of stress going on in the population as a whole. If you look at subgroups in the population, you always see the same. You see the female gender sticking out, you see the younger age group. Often it's the group between 16 and 30 we are talking about. It's not children we are talking about. Most of the studies are focusing on adolescents and young adults. We see the presence of chronic or psychiatric illnesses as an issue, unemployment as an issue, student status, which is a part of the younger age group, and frequent exposure to social media. What we also saw is that, especially in the younger age group, one of the reasons for their heightened stress is that they use mainly social media in order to get information. And the social media information is often a very negative information. And the social media have this characteristic that if you use a search strategy where you look at the negative messages, then the internet gives you more negative messages. So it gives you always more of the same. And this is a very difficult thing, because if I can use an information seeking strategy where I can selectively get negative and positive information and try to form an opinion on that, I'm much more able to cope with this than if I'm always getting only the negative information. So as a conclusion of this study, the authors say that the COVID pandemic is associated with highly significant levels of psychological distress that in many cases would meet the threshold of clinical relevance. In many studies, it has been right at the threshold. So it's very, very important. Everybody is saying it's very important to mitigate the hazardous effects of COVID-19 on mental health. It's a priority. And many states and organizations are focusing on that at the moment. So shall we go on to the next study?
Yes, please.
So this is a study about, because I said the threshold of clinical relevance, especially with the depressive symptoms, we see that at the moment. We see that women, younger age, student status, unemployment, prior psychiatric history, and those reporting greater negative impact on their quality of life. All those were at higher risk for increased anxiety and depressive symptoms. Again, we see the same risk factors we have talked about before. It's about the women, about the younger age groups. The youngest age groups and the males reported lower levels of compliance. And this is also important because what we saw in our studies and what other studies also say, that those with lower compliance have more stress, often. Higher compliance with the measures predicted lower depression scores, but higher anxiety. What does this mean? This means that people who show more compliance often feel more in control because they can do something. Whereas people who are not compliant often feel helpless because they have nothing, they feel exposed to what others are deciding upon them. And this explains a little bit the higher depression scores. Whereas with anxiety, it's a little bit more difficult because anxiety, I would say in a medium level anxiety, predicts higher compliance. So you have to have a little bit of anxiety in order to be compliant, because if you don't have any anxiety, you are not compliant at all. But if you are too anxious, if the anxiety gets too high, normally people react with shutting down, and then they are not compliant anymore. So with anxiety, I think it's a little bit more complicated than this one-on-one linkage between, or correlation between compliance and the measures. Again, also this study says, demonstrates the need for effective mental health programs. If you look at the trauma symptoms, trauma spectrum symptoms like the intrusions, the arousal, the avoidance. This is a study from Italy. The data suggested a wide range of these trauma spectrum symptoms that were reported in the Italian sample during the COVID pandemic in the first wave, I must say. Most of these studies are during the first wave, not all, but most. They showed negative effect, the intrusions, arousal, and avoidance, the core symptoms of PTSS, but also high levels of dissociative symptoms. What people said, for example, also in our studies, is they said it's like in a war, but without the destruction. We do a lot of interviews with people, and we see a lot of war metaphors going on. It's like in a war, or compared to war, this is similar, but on the same time they say, but we don't have a lack of resources in food or water. In this Italian study, they found particularly high rates of these core PTSS symptoms, not of PTSS as a diagnosis. Again, we have to be very careful not to say people are not everybody is traumatized. It's not about traumatization, but people show trauma symptoms. That's very important. Pre-traumatized people, on the contrary, they show really spectacular symptoms of traumatization at the moment. But it's important that in clinical practice we have to assess for trauma symptoms. And I think not only in clinical practice, also in our psychosocial interventions, we have to be careful to see also trauma symptoms in the people and do psychoeducation also on these symptoms. This is another study from Spain showing about the gender effect. In this study, around 40% of the participants showed psychological distress. Avoidance was a very, very prevalent symptom in the total symptoms sample for all genders studied. But the impact was higher for young people and for women, as we said before. What is to be said about the avoidance symptom is that to a certain degree, to be able to show avoidance symptoms is a good sign. As I said before with the social media, people who consume a lot of social media and are not able to avoid the topic, to just do something else, focus on positive things, they have higher stress levels than people who are not able to do any avoidance. On the other hand, people who avoid too much, avoid everything, like going so far as to have a conspiracy theory and say there is no virus at all. These people avoid very well, but those are not the people who are not distressed at all. In our studies, we see a high level of stress, especially in this group. So they have stress, but they avoid to confront themselves with it at the moment. So again, another study from another group showing that the gender, the lower perceived economic stability, also higher neuroticism and the fear of contagions are predictors of a higher PTSD symptomatology. We are now with the trauma symptoms again. So people who fear more that they can get infected, they show higher PTSD symptomatology. But here I suspect a confusion, because the fear of contagion is especially high in the healthcare personnel and in other personnel who works in very exposed areas. And these are mainly the women again. And so I think here we have a confoundation of PTSD symptomatology and the fear of contagion with the exposure. So I think it's more about exposure than about fear of contagion here. So the more exposed I am, the more I experience or may experience a post-traumatic stress symptomatology, like intrusions, arousal, and avoidance. So this study says that we should use specific protocols to prevent the possibility of developing symptoms in target populations. What does this mean in practice? In practice, it means that we have to ask people about their fear of contagion and about their exposure status. And not only about their fear of contagion, but also about their fear of infecting others. Because the higher this fear is, I infect myself and I infect others, the more stress I'm experiencing, and the more I am in need, perhaps I am in need for psychosocial support and some psychoeducation how to deal with this problem. But also for good information and on how to protect myself and others. And with good information, I mean information that is really based on science and information that is not only social media driven. This is a study that we did in Innsbruck, and this is just to highlight another aspect that we do not see in these generalized studies that I have presented until now. It seems that older people are not at risk in a mental health way, but that's not true. We have to look at certain population groups. We have to look in a more specific manner. Many of the studies at the moment are very, very big population studies that are done at different time points. Many of the studies are done every 14 days, have been done since March. They have been done every 14 days or every month since March. But in these whole population studies, you cannot focus on some groups. You cannot focus on migrants and you cannot focus on older people, because the group is so differentiated, so variable, that you lose the vulnerabilities within these groups. So you have to look at those groups specifically in order to find out who in this group is the vulnerable group, the vulnerable subgroup. And if you see the migrants, it's the refugees, the people, the asylum seekers, and the people who are working in different difficult situations, like migrant workers, I would say. Yeah, we find these especially in the nursing area, but also in the area of agriculture. And if you look at the older people, you see especially older people who are fragile physically, older people who are in nursing homes or who are in mobile care. These are the people who are highly at risk for the pandemic, but are at the same time very highly at risk for mental health problems. Because in the first wave, this one strategy in many, many countries was to isolate them. They were not allowed to see their relatives. They were isolated in the nursing homes, for example. Some of them, they just had to stay in their rooms for weeks, and people just came in to give them something to eat. They had no contact at all. And what we saw, for example, and there are many studies showing that isolation enhances mental health problems, but also physical problems. Many of these people have died because of the isolation, not because of the pandemic, because of the isolation. And what we also see is that their cognitive performance is going down. In our sample, we had about 50 participants. Some of them had dementia, a diagnosis, and some not. They were all living in nursing homes. And we tested them before the lockdown and after the lockdown. And what we saw was that after the isolation, the depression, the anxiety, and the subjective quality of life, they all got worse in the isolation. But after the isolation, when the isolation was ceased and they could meet their people again and they had their therapy again, the anxiety got less, the depression got less, the subjective quality of life got up, but the cognitive performance did not recover. So they did not recover in their cognitive performance. And some of them even got the diagnosis of dementia afterwards. So especially the cognitive performance is going down in isolation. So most countries have now learned in the second wave. In the second wave, for example, in Austria, there is a law now that you have to take measures not to isolate older people in a way that they get negative effects. And also in other countries, in Europe at least, I know that there are some measures taken against it, but still we have to be very careful about that. Another thing that is a little bit disturbing, I would say, is until now I said it's mostly about symptoms, but not about pathology. But if we look at the depression during the COVID outbreak, we see this is also 12 studies now who were included in this meta-analysis. This is a lot, and it shows that the prevalence of depression compared to 2017 is now 7 times higher, which is really a disturbing result, especially when you know that in former pandemic studies, we saw that during the pandemic, the levels don't go up normally. After the pandemic, they go up. So what we expect is that this level, which is very high at the moment, will even go much more up after the pandemic. So again, addressing mental health issues during and especially after this global health crisis should be of a primary focus. And what we all know from previous studies, that after the pandemic, we expect a high rise in depression, anxiety disorders, and in suicidality. So we have to be prepared for that. So we cannot only plan during the pandemic, we have to plan for afterwards. And afterwards will not be recovery for many, many people. Afterwards will first be a high rise in mental health problems.